Welcome to this space dedicated to the dissemination of scientific knowledge, designed for specialists, general practitioners, and students, as well as the general public interested in healthcare. In this edition, we present a detailed analysis of the study titled Primary Cutaneous Lymphomas in Children, a review of a case series with emphasis on diagnostic imaging and multidisciplinary management, a fundamental work for understanding the approach to these rare and complex childhood neoplasms. This research was published in 2026 by Dr. Ernesto Roldán-Valadez, in collaboration with a distinguished team of specialists from leading national institutions in Mexico. Throughout this video, we will explore how the team analyzed the clinical, histopathological, and radiological characteristics of these lymphomas, which originate exclusively in the skin and represent a significant diagnostic challenge due to their ability to mimic common skin diseases. We will also identify key findings regarding the importance of early biopsy, the precision of staging through CT and PET-CT, and the success of comprehensive therapeutic strategies ranging from advanced phototherapy to allogeneic stem cell transplantation. We begin this journey through medical science made in Mexico.
Legal disclaimer. This material is for educational and scientific dissemination purposes only. Its goal is to democratize access to the knowledge generated in specialized academic publications. Due to the dynamic nature of medical science, the information presented reflects the data available at the time of the original article's publication and may be subject to subsequent updates. Not medical advice. Under no circumstances does the information presented constitute a medical recommendation. The graphic resources used are only a representation of the article presented and are not completely accurate to human anatomy. For more information, you may pause the video.
Let's jump right into this explainer. Today, we're going to unravel a really profound clinical challenge that is hiding right in plain sight. We're looking closely at a fascinating recent study on primary cutaneous lymphomas, or PCLs, specifically in kids. Now, these are rare extranodal non-Hodgkin lymphomas that start entirely in the skin, with zero extracutaneous disease when they're first diagnosed. And let me tell you, they are absolute masters of disguise. So, whether you're a specialized oncologist, a med student, a family doctor, or honestly just a curious member of the public, this explainer is totally for you. In fact, it's pretty much mandatory viewing. Why? Because these conditions almost never show up in a specialized pediatric oncology ward first. They walk right into general pediatric clinics, everyday dermatology offices, and family practices. Knowing exactly what to look for here could quite literally be the difference between life and death. 3 years. I just want you to think about that number for a second. 3 whole years. That single number is the staggering average diagnostic delay for children suffering from mycosis fungoides, which is the most common type of pediatric primary cutaneous lymphoma. That is 3 years of failed steroid creams, completely incorrect diagnoses, worsening symptoms, and just agonizing uncertainty for these families before anyone figures out it's actually cancer. All right, here's our game plan. First, we'll talk about the clinical mimicry of this disease. Then, we are going to walk through 3 really impactful real-world cases from a pediatric oncology center to see how this actually plays out. Finally, we'll lock down the crucial clinical takeaways to help close that unacceptable diagnostic gap. Section 1, the great clinical mimic. Let's talk about why it actually takes 3 years to find a cancer that is literally sitting right on the surface of the body. The core of the problem is that these deadly extranodal non-Hodgkin lymphomas disguise themselves as super common everyday childhood rashes. We're talking things like atopic dermatitis, vitiligo, or pityriasis alba. To the naked eye, and sometimes even under a quick preliminary microscope exam, they look basically identical. To make matters worse, kids rarely show the classic symptoms that adult patients get, so doctors are essentially trying to hit a moving target while wearing a blindfold. Moving to Section 2, let's look at our first case. Refractory mycosis fungoides in a 16-year-old girl. Tracking her journey really exposes the danger of this mimicry. Initially, she came in with generalized skin inflammation and was completely misdiagnosed with juvenile myopathic dermatomyositis. But look at month 13. She suffered a severe flare with erythroderma covering over 90% of her entire body surface area. 90%! And she became refractory, meaning totally resistant to everything they threw at her. CHOP chemo failed. Radiation gave only a temporary fix. Biologics did nothing. She was locked in this grueling 3-year nightmare. But her story does have an amazing breakthrough. Because the conventional stuff failed, her doctors escalated to a massive intervention. Haploidentical allo-HSCT. Basically, this is a stem cell transplant from a half-matched donor, and the goal is to completely reboot the patient's immune system. And remarkably, it worked. By day 76 post-transplant, she didn't have a single active skin lesion. She hit full remission and eventually moved on to adult care, totally disease-free. Let's jump to section 3. Case 2, an aggressive CD8-positive lymphoma in a 3-year-old girl. This one is really tough, but it shows exactly what we're up against. Tracking this timeline is just terrifying because of how fast it accelerates. Early on, her skin lesions were misdiagnosed as pemphigus and hydrohonia vacciniform, which is a rare sunlight-induced rash. Steroids did basically nothing. By month 11, she hit a crisis point. She was referred out with hemorrhagic blisters, high fevers, and a swollen liver and spleen. The real diagnosis? Aggressive primary cutaneous cytotoxic CD8-positive T-cell lymphoma. Just 1 month later, the cancer invaded her tissues so fast it caused acute compartment syndrome in her arm. They literally had to do an emergency surgical fasciotomy just to relieve the pressure. And despite incredibly aggressive chemo and surgeries, the disease kept progressing and she tragically passed away at month 23. So, what was the viral culprit lurking behind this incredibly aggressive case? It was the Epstein-Barr virus, or EBV. EBV is a well-known oncogenic viral driver. In kids, EBV-associated cutaneous disorders can heavily overlap with these aggressive lymphomas. It's a stark reminder for all of us. If a pediatric patient presents with suspicious, atypical lesions that mimic hydroa vacciniform, targeted EBV testing isn't just a bonus. It is an absolute necessity to figure out what you're really dealing with. All right, section 4. Case 3 is a relapsing ALCL in a 10-year-old boy. This one highlights a totally different clinical nightmare. The chronic relapser. Can you believe 4 years passed before they figured this out? For years, his recurring facial and limb swellings were just treated as cellulitis with rounds of standard antibiotics and steroids. Finally, a biopsy confirmed it was primary cutaneous anaplastic large cell lymphoma, ALCL for short, which was CD30 positive. He went through a heavy pediatric chemo protocol and actually cleared it. But then the cancer relapsed. And here is the truly wild part about cancer biology. When it came back, a new biopsy showed the lymphoma had completely dropped its CD30 marker. It literally mutated just to hide from the targeted therapies. To fight back against that mutating relapse, his multidisciplinary team pulled out a fascinating, highly specialized radiation technique, total skin electron beam therapy, using the Stanford technique. This delivers a heavy dose of radiation to the entire surface of the skin. But here's the genius part. The electrons only penetrate superficially, so they destroy the lymphoma cells in the skin without frying the vital deep organs underneath. It worked incredibly well, and today he's successfully maintained on light therapy. Section 5. Crucial clinical takeaways. We've seen the devastating human cost here, from grueling stem cell transplants to tragic losses to mutating relapses. Now, what do we actually do about it? When you look across all these cases, a few glaring red flags pop up that should instantly raise our suspicion. First, the diagnostic latency was way over 6 months for everyone, up to 4 years in that last case. Second, and this is really surprising, a highly elevated serum IgE was found in all 3 kids. Normally, you associate high IgE with simple allergies or everyday eczema, but in the context of a stubborn rash that won't heal, that's a huge red flag. Finally, a single biopsy just doesn't cut it. These tumors evolve over time, meaning they look different from month to month and spot to spot. Repeat multi-site biopsies are absolutely mandatory. So moving forward, here is the gold standard protocol if you're dealing with a strange, stubborn rash in a child. Step 1, do not wait. Perform an early biopsy on any atypical rash that ignores standard treatments. Step 2, order targeted ABV testing if the clinical signs point that way, just like we saw in the tragic second case. Step 3, get full body imaging, like a CT or PET-CT, to stage the disease and check the organs. And Step 4, enforce multidisciplinary management. Dermatology, oncology, radiation, and pathology all need to be in the exact same room talking to each other. But beyond all the clinical data and protocols, we can't ever forget the extreme emotional toll this takes. Families endure years of utter confusion, terrifying medical complications, and sometimes unimaginable loss. Their incredible resilience and their total reliance on a united medical team is exactly why improving our diagnostic pathways is so absolutely critical. I'll leave you with this final thought. Now that you know exactly how primary cutaneous lymphomas disguise themselves, how will you help unmask the great clinical mimic in your own community? Whether that means ordering one extra biopsy, second guessing a stubborn eczema diagnosis, or just advocating for specialized care, closing that 3-year gap starts right here with us. Thank you so much for joining me in this explainer, and keep questioning what you see.
The reference for the article from which this information was extracted is displayed on the screen. Thank you very much for your attention and for joining us until the end of this analysis. If you found this review helpful, we invite you to share it with colleagues, residents, students, and anyone interested in these topics. Don't forget to subscribe and turn on notifications. This material is for educational and scientific dissemination purposes only.